Before we define anatomy, look at the problem on screen. On the left is a clean, labeled picture. On the right is the same human region turned into a three-dimensional model and then cut as a cross-section. A beginner can recognize the first image and still feel completely lost in the second. That is because anatomy is not a test of whether you can remember one picture. It is a test of whether you know where structures are in space. The body can be rotated, layered, moved, and sectioned, but the relationships between structures still give you clues. In this course, we are going to build those relationships deliberately. The goal is not to memorize 1,000 isolated labels. The goal is to build a mental body that you can rotate in your head and still understand. To make that process repeatable, we will use one simple Med Studious framework, ORBIT. O means orient. Establish the body, region, and viewpoint before you name anything. R means recognize. Find the big landmarks and boundaries. B means build. Add layers, compartments, and neighboring structures. I means imagine. Rotate the region or picture what it would look like in a cross-section. T means trace. Follow important nerves, vessels, ducts, muscles, or spaces through the region. Orbit is not an official anatomical term. It is simply a study scaffold that forces you to think in the right order. When an image looks unfamiliar, do not jump straight to guessing a label. Run ORBIT. That habit will follow us through gross anatomy, neuroanatomy, imaging, and even exam spotters. Human anatomy is the study of the structure and organization of the human body, but structure does not mean a list of nouns. For any important structure, anatomy asks at least 4 questions. What is it? Where is it? What is around it? And what does it connect with or pass through? Imagine learning an artery only by its name. That name becomes useful when you know where the artery begins, what region it enters, what structures lie beside it, where it branches, and what tissue it supplies. The same is true for nerves, muscles, organs, and spaces. So when you study anatomy, move from labels to maps. A label is one data point. A relationship map is a network. Clinical anatomy and exam reasoning depend far more on the network than on the isolated name. Anatomy has several branches because the same body can be studied at different scales and from different viewpoints. Gross anatomy looks at structures visible without a microscope. Regional anatomy studies everything in one area together. Systemic anatomy follows one system through the whole body. Surface anatomy connects deeper structures with the living surface. Radiological anatomy asks how those structures appear on X-ray, CT, MRI, or ultrasound. Histology moves to the microscopic level. Embryology asks how adult structures develop over time. Neuroanatomy maps the nervous system and its pathways. These are not separate bodies. They are different windows on the same body. Our curriculum separates them into playlists because each needs a different visual method, but the underlying logic remains the same. Orient the view, find landmarks, understand relationships, and trace continuity. Here is one of the most important early lessons in anatomy. One picture is never the whole structure. A bone or organ can look dramatically different from the front, from the side, and in cross-section. If you memorize only one drawing, your recognition becomes view-dependent. Instead, ask what stays true when the view changes. Which landmark is still present? Which structure stays next to another? What boundary is still crossed? Those invariant relationships are much more useful than remembering the exact color or shape of one illustration. Atlas colors are teaching conventions. Cadavers and medical images will not copy them. So when you revise, deliberately change the viewpoint. Cover the labels, rotate a model, compare an atlas with an imaging slice, or sketch the same region from another angle. You are training spatial understanding, not photographic memory. The first ORBIT step is orient. Before identifying a structure, establish the coordinate system. What part of the body are you looking at? What side is shown? Are you viewing from the front, back, side, above, below, or a cut surface? Is this a surface view or a section? Many wrong answers begin because the learner skipped these questions. In the next video, we will formally learn anatomical position, planes, axes, and directional terms. For now, keep one principle. Orientation comes before identification. Think of it like reading a map. A street name is not helpful if you do not know which way north is. In anatomy, the standard reference system lets students, radiologists, and surgeons describe the same three-dimensional body without ambiguity. Build the habit now. View first, label second. Once you are oriented, do not chase every small structure. Recognize the large anchors first. A landmark might be a bone, a joint, a major organ contour, a cavity, a large vessel, or another feature that is easy to find. Boundaries tell you which region or compartment you are in. These anchors dramatically reduce complexity. Think of entering an unfamiliar city. You first locate the river, a major road, and a central station, not every small street. Anatomy works the same way. Later, when we study the axilla, the pelvis, or the popliteal fossa, boundaries will tell us what belongs inside the space. On cross-sectional images, large bones and organ shapes can orient the entire slice. Find the big map first. Small details become easier once they have an address. Now build depth. The body is layered, and many regions are organized into compartments. Instead of memorizing 10 structures in a random list, place them from superficial to deep and ask what lies beside what. Think of a target structure as the center of a neighborhood. What is immediately superficial? What is deep? What crosses in front of it? What runs with it? Which fascia or boundary contains it? We will formally learn directional terminology in the next lesson, but the relational habit starts here. This is also why anatomy remains recognizable when the colors change. A nerve may not look yellow in a cadaver, but its position beside a known vessel or between two muscles can identify it. Relationships are the stable grammar of anatomy. If a page feels crowded, we build it as layers and neighborhoods.
The I in orbit means imagine. Take the map you have built and mentally change the view. What would this region look like if you turned it 90 degrees? What if you cut across it at this level? Cross-sectional anatomy is where weak spatial models are exposed. On CT or MRI, a muscle may appear as an oval, a vessel as a small circle, and a bone as a cut profile. Do not treat that slice as an unrelated picture. It is one level through the same three-dimensional region. Orient the slice, find the largest landmarks, place the major compartments, and then identify smaller structures. If you move the slice upward or downward, expect shapes and contents to change. The skill is reconstruction, using one section to infer the whole. The final step is trace. Many structures are not points, they are journeys. A nerve begins in one region, crosses a boundary, travels with other structures, gives branches, and reaches a destination. An artery branches and passes through several spaces. A duct connects one organ to another. If you memorize only the start and the end point, the clinically important middle remains blank. So trace a route using checkpoints. Where does it start? What passage or compartment does it enter? What landmarks does it cross? What accompanies it? Where does it branch or end? This approach also makes injury patterns more logical because a structure becomes vulnerable where its course places it near bone, inside a tunnel, or close to another structure. Later videos will supply the specific maps. Orbit gives you the method for learning them. Textbook diagrams often freeze the body in one position, but living anatomy moves. Joints rotate, muscles change length, the chest changes with breathing, and organs can shift with filling, posture, or movement. That means a useful three-dimensional model should be dynamic. When you look at a structure, Ask not only where it is at rest, but what relationships may change when the region moves. This is where anatomy begins to connect naturally with function. The shape of a joint influences the motion available. The position of a muscle relative to a joint affects the action it can produce. We will study those details in later videos, but the principle matters now. Anatomy is architecture, and architecture determines possible movement and access. Try to imagine the body as a moving model, not a collection of frozen plates.
Why invest so much effort in spatial anatomy? Because the same internal map appears in different clinical forms. Surface anatomy helps us relate what we can see or palpate to structures underneath. A cadaver reveals real depth, texture, and variation. Imaging shows internal anatomy in living patients, often as sections. Clinical examination, surgery, and procedures all depend on knowing what lies between the surface and a target, and what neighboring structures must be respected. This lesson is not teaching a procedure, but it is teaching the reasoning that makes procedures understandable. Clinical anatomy is not another set of facts added after gross anatomy. It is gross anatomy applied to a real problem. If you know the map, symptoms, imaging findings, and risk patterns become easier to explain. The vocabulary starts in the anatomy lab. The same spatial language continues in clinical medicine.
Let us make the common traps visible. Trap 1, label-only learning. You know the name, but not the location. Trap 2, one-view learning. You recognize a structure only in one diagram. Trap 3, depth blindness. You ignore what is superficial or deep. Trap 4, endpoint-only learning. You know where a nerve starts and ends, but not the course. Trap 5, color dependence. You rely on an atlas convention instead of relationships. Trap 6, section panic. You skip orientation when an axial or coronal image appears. The correction is not to memorize more pictures. Return to orbit. Orient the view, recognize landmarks, build the neighborhood, imagine the three-dimensional shape, and trace continuity. That sequence converts an unfamiliar image into a solvable spatial problem. Now, pause the video and use orbit on this simplified, unlabeled region. Do not guess the marked structure yet. First, orient the view. Second, identify the biggest landmark. Third, decide which layer or compartment contains the target. Fourth, look at its neighbors. Fifth, trace where the structure seems to come from and where it continues. Only after those steps should you choose an identity. Notice what we are doing. We are not asking whether you have seen this exact picture before. We are making the picture answerable from relationships. This is the method you should use in cadaver spotters, image-based questions, and later cross-sectional anatomy. If your first guess was wrong, audit the step that failed. Was the view wrong, the landmark, the depth, the relation? Correct the map, not just the answer. Bring the lesson down to one sentence. Anatomy is structure in space. To think in 3 dimensions, use orbit. Orient the view, recognize landmarks, build layers and relationships, imagine rotation and sections, trace courses and connections. Remember that the body is dynamic and variable, and that clinical anatomy is the application of the same spatial map to the living person. If you remember only names, unfamiliar views will defeat you. If you remember relationships, you can reconstruct. The next lesson gives us the formal language for this map: anatomical position, planes, axes, and directional terms. Those words are not vocabulary for vocabulary's sake. They are the coordinate system that lets us describe 3-dimensional relationships precisely. Before you leave, say orbit once from memory. Then move directly to video 02 and learn the language that makes the map shareable.